this week on the BackTable podcast.
Absolutely. It is the same thing. It is choosing the right treatment at the right time. So that's why I think the pathways and to treat the disc are more complex than other pain generators. We cannot do always the same thing for the same anatomical region, but we note that there is different pathologies within the disc, and you need to choose the right treatment for the right pathology within the disc.
Hello, everyone, and welcome to the BackTable MSK podcast, your source for all things musculoskeletal. You can find all previous episodes of our show on Spotify, Apple Podcasts, and on backtable.com. This is your host, Jacob Fleming, and back with me today is my Canadian brother, Olivier Clerk. It's good to have you back, Dr. Clerk. How are you?
I'm doing fantastic. Thanks so much for the invitation again. Very much excited for another few minutes with you, and I think we have a very interesting topic again today, so a little bit on the same line that we did last time.
Absolutely. So last time we discovered, hopefully did not discover, some of our audience members maybe discovered, but we discussed basivertebral nerve ablation. Excellent episode for anyone who's looking to get into it and learn a little bit more. And today we're kind of continuing the theme, like you said, talking about some anterior column treatments. So this is an area, honestly, one of my favorite areas of treatment and kind of a neglected area as well, but one with a lot of exciting new things coming out. So we're going to do a little bit of a two-part here. And so the first part, we're going to focus on the basics of disc access so that our listeners can learn a little bit about symptomatic lumbar degenerative disc disease, as well as some of the technical aspects for approaching disc injections and how this fits into our evolving treatment paradigm. And then in part two, we'll discuss something you've been working on quite a bit with it, which is disc augmentation.
Yes.
One of the most exciting developments coming out. So for our listeners, after part one, we'll get into the nitty gritty of some exciting developments. And this first part should hopefully be chock full of some practical information. So we'll just jump right in. So Dr. Clerk, tell us a little bit about what is degenerative disc disease and what are some of the anatomic and maybe physiologic ramifications that arise from this ubiquitous process.
This is a big topic to cover because there's quite a lot of things to say. First, just the pure impact of it, right? So when we're talking about disc degeneration or degenerative disc disease, it is by far the most common musculoskeletal problem in the world, right? We're talking at any time and point about 15 to 30% of a population that will be affected by it, right? So economical repercussion of this issue are huge. Often whenever you're reading a paper on PubMed about low back pain and chronic low back pain, we're talking about close to $100 billion annually that affects overall the population in direct cost. And you add another about $20 billion in loss of wages, decreased productivity. So it is, low back pain overall is a huge problem, and a good portion of it relates to disc, right? So it is often, in my opinion, under-recognized in some studies. That's in terms of importance. We're talking about 50 to 60% of axial low back pain that will have some type of discogenic pain, some axial low back pain that will be purely discogenic, and some that will be mixed with facets and disc. And when we're talking about disc, sometimes it can be, we often relate to the disc and plate complex. So I'm putting together vertebrogenic and discogenic pain. But it is a big issue in our society, and unfortunately still under-recognized. But we're just starting to get some good treatments. And I think as the new technologies arises on the market, this problem will be hopefully better recognized and better identified and better treated down the line. It's a complex pathophysiology. Maybe the first way to address it would be to talk about the disc, right? The disc is a structure that contains centrally proteoglycans, right? So those negatively charged cells. with a collagen band that surrounds those cells called the annulus. Annulus is composed of two types of collagen, type 1, type 2. And as the disc degenerates, you're losing some of that hydric content. You're losing those proteoglycans, and you do see tear within that disc. And those tear can be located more centrally or can extend up to the outer portion of the disc, so the annulus. We'll come back to that, but those tear can be very frequently very painful. And then after that, you can have loss of height of your disc and various other problems that can come with that as well. But all those processes can be painful and can be now evaluated objectively with different imaging techniques. So in a nutshell, this is what's happening when we see disc degeneration. And the cause of disc degeneration is not yet fully understood. We know that it is largely mediated by genetics, probably more than environment and mechanical stress. We know that mechanical stress and the environment can have an impact on the disc, but it is a highly genetic mediated process. So that's in a nutshell what we see and what we know about disc degeneration.
Thank you. That was an excellent overview. And like you said, it's a very complex pathophysiology. I've seen some of these more basic science type diagrams going into the molecular details, and it's really fascinating. And you start to understand when you look at the MRIs of these patients, just the spectrum of disease. We've seen that, just mild disc degeneration with a little intranuclear cleft versus something that's just modified Fleming grade 8, just totally black disc with in-plate erosions and edema and things like this. And when you first get into looking at these imaging studies, I remember being pretty overwhelmed as a radiology resident that some of this stuff looks pretty gnarly. And I've seen some things that are just very exuberant disc and in-plate degeneration be called things like osteomyelitis. So it can be a little tricky, and you'll see lots of different things. But one of the toughest things that I found is that this almost ubiquitous process of severe axial low back pain that probably most adults experience at some point in their lives related to disc degeneration. A lot of times it's something as simple as a little annular fissure, like you said. And these have subtle findings that can easily be missed or ascribed to other things. And you mentioned that it's often underdiagnosed, and I agree with that. I've seen a lot of patients who come in, often referred for something else. Well, it's piriformis syndrome, or it's the SI joint. And in fellowship, whenever we got a consult for SI joint, I knew right off the bat it was about a 95% chance it was not going to be the SI joint. Yes. And almost definitely the L5-S1 disc. And so it can be very difficult to kind of weed all this out. And especially, I think you and I were fortunate, I think, that we got to train in an environment where we did a lot of disc work. And when I talk to some of my other colleagues, whether they're neurosurgeons or orthopedic surgeons or other pain physicians from other specialties, it's difficult to talk about. It's like we're talking about different things. Yes. And so this gets to my next point, which I call kind of the old paradigm and the new paradigm for discography. And you talk to most people about discogram, and interventional radiologists who've been in practice for a while maybe did some of the old provocative discography, and they're like, oh, it's the worst thing ever. You basically just try to pressurize the disc and see if it's painful for the patient. And it's pretty brutal. So that's what I would consider kind of the old paradigm of provocative discography. And then you're basically seeing, okay, is that their source of pain? And historically, that's been used mostly to decide whether to fuse them. And so that kind of all or nothing approach, it's either do nothing or fuse them. Yes. I think hopefully that will change. But so I'd consider that the old paradigm. I consider the new paradigm or newer paradigm, the idea of anesthetic discography. So could you just tell us a little bit about that?
Yeah. So discogram overall is a diagnostic tool to confirm basically if the disc degeneration or the annular fissure is the source of pain of the patient. But it provides another component also. And this other important component is what type of tear also is seen within the architecture of the disc. One of the things that we haven't mentioned yet is that when the disc degenerates, it creates also other things on the segment, right? So you do see a fair amount of instability that is caused by disc degeneration. You lose inner architecture within the nucleus. You have the inner annulus fibrosis that will go internally toward the nucleus. And if you take a look on biomechanical studies, you'll see that the disc move in shear motion with way greater amplitudes than a regular disc. So that's something that we see also. And we see that as the disc degenerates further, you see even a posterior loading on the facet joint and on the posterior portion of the disc, so on the posterior annulus. And often at this point, you're going to see herniations appear, you're going to see tear appear, and those tears can be quantified and further characterized with the discogram. So originally, as you mentioned, the discogram was a provocative test or a stress procedure. So we were injecting contrast under pressure, under a certain pressure, to determine if the patient has pain while injecting. So it could be a pretty brutal test. So we were increasing pressure, up to 50 psi to try to determine if that was the pain generator for a patient. And this is something that we're trying to do less and less. We're trying to do a negative discogram, which is actually just injecting lidocaine within the disc to determine if the patient has relief of his pain. And in my opinion, this is a better way to determine if this is a pain generator of the patient, because he can try it out at home. He can go back home, go back with a pain journal, and for a couple of hours, determine if his maneuvers that normally would be painful, so bending forward, sitting, being in transit in between the clinic and his apartment, hurts less with the freezing in place. So that's a better way to determine if this is the pain generator. And then the other component is to determine the type of tear. So this is something that we can see and quantify with a CT discogram. So we can even do a 3D recon after injecting dye within the disc. And there's different type of classification that allows us to determine the type of tear. And this is also a test that is more and more important as we are injecting permanent implants or permanent biomaterial within the disc. You want to make sure that it stays within the border of the annulus, and you want to stress this annulus, making sure that this annulus is competent. So there's different type of tear, different classification that use a classification called the Modified Dallas Discogram Scale that we use on a fairly regular basis now to be able to determine if those patients will sustain the stress of injecting something within the content of that disc.
Excellent. And so I'm glad you brought up the concept of CT. So those of our colleagues who've done CT myelograms before, this will make perfect sense. I haven't personally done any of these yet, but I'm looking forward to starting it in my new practice because I think you can get so much information from these. Can you tell us just a little bit about how do you do CT discogram in your practice? Do you routinely do that on all patients or just in certain situations?
Well, mainly in patients that we think that we want to proceed with a permanent implant, so intradiscal hydrogel or other type of implants that we have access to. Whenever we're concerned that there may be, we want to make sure there's no expulsion of that implant. So there's 5 grading scale that we utilize. So grade 0 of the Modified Dallas Discogram Scale, which is a normal disc. Grade 1, you're going to have a small fissure, mainly centrally. Grade 2, you're going to have a radial fissure that can extend up to the middle third of the annulus. Grade 3, up to the outer third of the annulus. Sometimes you may see a little bit of a circumferential tear along the outer annulus, but it should be less than 30%. And whenever you're in a grade 4, you have more than 30% of this outer circumference tear. So these are the most frequently seen tears. I would say in a degenerative disc, more frequently than not, it's going to be a grade 3 or a grade 4. So that's going to be the differential to the two types that we want to differentiate. The grade 5 is probably the most important to diagnose. So the grade 5, you're going to have extravasation of contrast within the ventral epidural space. So whenever you do see that, this is a no-go. You don't want to inject those patients with any type of hydrogel or any type of permanent implant. What we discovered with our, after doing multiple hundreds of and thousands of them, one point that is often forgotten is that you're injecting this dye with a patient that is in a supine position, right? So that is prone, so on their stomach. So which is very different that if you're stressing the disc, right? So what we noted is just the fact in between the procedural room and the CT scan, just the fact of walking less than 100 meters, that axial compression in some case would upgrade the discogram scale. So the patient may pass from a grade 3 to a grade 5 or a grade 4 to a grade 5. So that axial loading on a disc that contains contrast is important because now you're really able to determine if this disc is patent or not. So that's something that we discovered while gaining experience while doing that. And to me, that this has been a practice, a game changer, because now we're virtually stressing all discogram like that to make sure that they are fully competent to receive an implant.
So interesting, and such an important part about the dynamic aspect of the disc. And you alluded to this earlier, talking about some of the anatomic ramifications, as you said, with the instability that arises, experience shear forces. And one of the things that mystified me for the longest time was this phenomenon of what's sometimes called vacuum disc. And so we see this often in the supine patients, like you said. Can you tell us a little bit about the significance of that particular finding?
Yes. The vacuum disc. So it is a phenomenon that we see in what we call grade 7 tear. So basically there's almost no more content within the nucleus. So we see a annulus that can be competent or not, and there's just a void of nucleus. So air is seen there, and that creates what we call vertical instability. So if you ask a patient to do a FlexX X-ray, you're going to see that the opening of a alligator mouth. You're going to see significant widening often of the ventral portion of the disc. So this is something that we see in later stage of this degeneration, often those modified Fermin grade 7 or 8. Sometimes you can see fluid, so T2 hyperintense, that can be mistaken for residual nucleus, but actually it's purely just fluid. And in other cases, you're going to see purely just air, and that you can see on your T1 sequences as a horizontal line. So yeah, that's something that we see fairly frequently and demonstrate a certain type of instability called vertical instability.
It's such an important finding to keep in mind, is these interdiscal gas, and sometimes, like you said, kind of a disc seroma. See this a lot of times with a very degenerated disc, and I've had to catch myself a few times because sometimes you see this high signal in the disc and you may be concerned about infection, especially if they have pretty exuberant modic changes. Oftentimes that'll go hand in hand with the modified Fermin 7 or 8 scale. So basically just a totally trashed disc. And like you said, if you look at the standing FlexX, that disc space is almost completely collapsed. And yet when you get them supine or prone for imaging study, a lot of times you'll see it open up and it kind of pulls that gas or that fluid out of solution is the basic way I guess I think about it. But I've really noticed that a lot more between imaging studies, and I've actually found it very useful comparing FlexX films with the MRI. And I will say, coming from kind of a non-surgical background with Dr. Beal, I think I can count the number of times we ordered a FlexX on 0 fingers. And so we didn't do it a whole lot and get pretty good at seeing indirect signs of instability. But I've found more and more, I like to get standing films on my patients. I feel like it gives you a lot more information before you even get into the procedure room. And I've found a lot of patients with discogenic or vertebrogenic pain when I'm just kind of reading the standard lumbar spine x-rays off the list. You see that disc gas, especially when they're standing up, that thing is very loose and quite possibly painful.
Absolutely. And you get good at reading those cases too. At the beginning, it can be a little bit more challenging, or you don't really know what to look for, but it really changed your practice, right? I mean, if you have significant instability at a level, you will not treat this patient the same way. If you see that between the flexion and the extension, you have a position-dependent anterolisthesis of 5 millimeter, you don't want to inject, hydrogel within that disc, right? I mean, it needs to be very stable, and this patient needs to consult, one of our, orthopedic spine surgeon colleagues or neurosurgeon. Yeah, so that does change drastically the management of those patients, and these can lead to big misses. So, that brings me to, whenever we're assessing or treating the disc, it's by some of our colleagues love it. Some of our colleagues try to stay away from it because it is a bit more refined, a little bit more complex than other structures, because there's more to take into the equation to determine where to go. And right now, basically, the algorithm are not clearly defined. They're at their infancy, but we do still have some good treatments for stable axial discogenic back pain. It is just to choose the right treatments for the right patient.
Excellent. And so talking about the right patient, let's give just a bit of an overview of how to identify patients with symptomatic lumbar degenerative disc disease. What are the common signs that you see and imaging findings?
Yeah, and that can be very easy once you know how to do it. So it is virtually three things, right? So pain with axial loading, pain with sitting, pain with forward bending. So you can ask the patient to do it in front of you. You can ask the patient if they have pain while sitting for extended period of time, if they always switch from one buttocks to the other, if they have difficulty bending forward, touching their boots, putting their socks on. So those questions, with those three questions, normally will really orient you in the right direction. And after that, you take a look at the MRI. If you see sign of disc degeneration or T2 high intensity zone or annular fissures, bingo, that will likely be the diagnosis. So it's a fairly easy physical examination or a questionnaire that really will change your practice in a certain way. The other thing also is that, when you start to look into that, you see that some professions or some individuals will really tell you exactly what their issue is, right? We see, for instance, a lot of surgeons or a lot of individuals that tend to bend forward about 15 degrees. So this is one of the angulation that will really stress more your posterior annulus and create pain on your disc. So once you understand the pathophysiology and how to stress the disc, it is a fairly straightforward physical examination or questionnaire to ask the patient.
I agree. And it's one of those things that once you start recognizing it, you realize just how common it is. And of course, there are cases where, like you said, you may have a combined discogenic and facetogenic kind of picture. And those are a little bit odd because, I have pain when I'm sitting, but other times I'll have pain if I'm extending and things like that. And that's when you do have to recognize that there can often be multiple pain generators. But I would say far more cases where the disc or the anterior column is the pain generator without the posterior column involved. And like you said, it's an easy questionnaire. And I have to give shout out to probably my favorite, the greatest of all time, the GOAT of physical exam maneuvers, which is sustained hip flexion, is my favorite maneuver. And so all it is have the patient lie on the exam table, help them bring their legs up to 90 degrees, and then ask them to slowly lower while you kind of keep your hands there so they don't just completely fall over. And basically reproducing any sense of that pain while they're doing that with this slow, sustained hip flexion is a very good sign of anterior column pain. So that's one that I love to incorporate into my perfunctory interventional radiologist physical exam. But it's just one of those things. It's like it's so simple. It does give you a fair bit of information.
It's so simple, and this test is fantastic. And it is, even for us interventional radiologists, we're able to do it. Often you hear that radiologists are not doing physical examination. Well, there you go. Like every Tuesday, I'm evaluating about 45 patients for mixed axial low back pain to compression fracture to, so we're doing it. And I think once you start doing it, you become really good at it and you recognize pattern, right? We're good for pattern recognition in radiology. And that's what we're doing here with physical examination. And I really enjoy it because I'm able to correlate. Often we put in our reports, or we used to, but try not to say correlate with clinical presentation. But I mean, you can do it yourself. You can take a look. You can assess the patient myself. And you take a look at the MRI. It's very valorizing, and sometimes you're wrong and you learn from it. But more frequently than not, you're right. And especially if you know how to read spinal imaging, you're gonna be really good at determining what the issue is and orienting the patient in the right direction. And those patients will be forever grateful because often they come to you and they've seen a bunch of other specialists. They don't really understand what's going on, and then you can find a solution for them.
Completely agree. And on that segue, talking about the actual imaging studies, one thing that comes up very frequently is figuring out what is the symptomatic level. And so often we have patients, into their 70s or 80s who have, I call it pan-lumbar disc degeneration. Just all 5 lumbar discs are just gone, basically. And that's very difficult, especially if you're looking for a single level to treat. It probably is a multi-level type of thing. And so there are cases where there are 2 or more symptomatic discs. There are some times when it's kind of a slam dunk to say this is the symptomatic level, especially based on imaging findings like high intensity zone, annular fissure, like you mentioned, or just out of proportion degeneration compared to the other discs. And I would say you see this very frequently, especially in the 35 to 55-year-old crowd, often a 4-5 and or 5-1 disc that's a little bit or significantly out of proportion to the degeneration in the other discs. And that 1 or 2 has a very good chance versus there's basically a 0% chance that it's coming from the other discs. But could you tell us just a little bit about your approach to navigating single level versus multi-level phenomenon?
So again, it starts with physical examination. So if it seems to arise from the anterior column and you have one disc that is degenerated, or you have a T2 high intensity zone, more likely than not, this is where it's going to be coming. But if you have multiple discs that are degenerated, agreed, it can be challenging to determine which one is the source of pain. But again, you have subtle signs that can orient you in the right direction. Often you will have to do discogram on all those levels or many of those levels. So although I don't really do the classic provocative discogram, I ask the patient while I inject the dye if this correlates with where he or she has pain. So that's the first part. And then as the discs are degenerated at multiple levels, well, often I'll just treat all levels depending on the type of treatments that you're aiming for. But more frequently than not, there's a little bit of a theoretical aspect of it to try to find where the pain generator is. If you have, just like when you're assessing facets joints, it's interesting to know if there's one facet joint that is more painful than the other. But in reality, if you see osteoarthritis, from L3 to S1 on the left side, well, more likely than not, you will treat just all 3 levels rather than spending a lot of time trying to assess if there's one joint that is more painful than the other. So tend to have a little bit the same approach with disc. Often I will first do that provocative aspect of it while I inject. And the other thing is recognizing basically there's some that have T2 high intensity zone. Other techniques also in the imaging can be useful. But again, at this point, in my opinion, often you have a little bit of pain that will be coming, let's say, from the L3, L4 level, a little bit more at the L4, L5, and some, but almost none at L5, S1. So what do you do in those cases? Do you just treat the more painful one, but you're still going to have, 30 to 40% pain? So more frequently than not, I take care of all levels there. But if you wanted to assess that further, well, first, an important point to make is that even in those modified Fleming grade 5, without the high intensity zone, when you do discogram on them, you will see tears. So even if you don't see the high intensity zone, some of those discs can be highly painful. So you cannot just rely on the T2 high intensity zone to target disc. That's another reason why I tend to do more discogram based on the if I see presence of degeneration. But the other modality that can be useful is spectroscopy. So spectroscopy also that we do can be useful also to determine if there's presence mainly of some lactate markers. So normally you're going to see a reversal of the ratio between proteoglycans and lactate. And that can be useful as well. It does take time, so we don't do it on every patient, but we do it sometimes whenever there's a good reason to be extremely precise within the disc that we want to treat.
Thanks for that excellent overview, and thank you for the allusion to MR spectroscopy of the disc. This is one of my kind of nerdy radiology interests I get really interested about. And I remember I told one of my co-residents, who's one of the smartest people I know, he is a neuroradiologist now, but I mentioned this, I had learned about it at ASSR a few years ago, and it necessitates kind of a show of its own. But basically I was telling my friend about this. I'm like, oh yeah, some people are using MR spectroscopy on the disc to, look at the different ratios of molecules and mediators and figure out what is the symptomatic level. And he was like, no, they're not.
Yep, you can.
From a neuroradiologist,
You totally can.
That's silly. That doesn't make any sense.
Totally can.
But to you and me, yes, and anyone who treats patients with low back pain, it's like, yeah, I mean, that has the potential to be a real game changer. And of course, I think there are some situations, I don't have that available currently. And so I definitely, in the patient who has a multi-level disease, I opt for starting off with what I refer to as a shotgun approach. So basically, you kind of have a shotgun approach to discography where you inject all the discs, and we'll get into the actual technique momentarily. But inject each of those levels, you look for a pain response at each level as well. And that gives you more information, even though you're injecting all of them. So for example, I did a 3-level discogram on a gentleman a few weeks ago, bottom 3 levels, and similar situation to what we were discussing. But when I injected 4 or 5, he almost jumped off the table, despite the fact he was sedated. And so I knew he was exceptionally tender there. And so that gives me some more insight into, okay, he may be symptomatic from all 3 levels to a degree, but that one seems to by and large. Yep. But still, I didn't know that beforehand. And so I started off with the shotgun approach. And that's pretty much, I think, what you and I have both been taught to do. Yep. And that's a practice that I keep. And I contrast that with, of course, what Dr. Beal refers to as the hunt and peck approach. And so that's basically when you are maybe moving towards doing something like an implant or a therapeutic injection, and you may do literally 1 level at a time and allow the patient to go kind of through the formal process, recover from sedation, see if they feel better, and you can kind of go down the list. Honestly, it's been relatively few times that I've ever had to do that, where you inject a patient more than once. Usually there's other kind of things like that, like the concordant pain response being related more to 1 level. I find that those kind of things give you so much additional information that even though you start off with this challenging diagnostic test of figuring out what is the symptomatic level among many levels, if you start off with the shotgun approach, it will almost invariably lead you towards the answer. That's just my opinion.
Completely agree. It happened to me a few times, and most of the patients that I had to do a second discogram, it's mainly individual that I see very early stage of this degeneration. In those cases, sometimes it can be even difficult to inject your anesthetic to confirm that this is the source of pain. And in those cases, I tend to see a little bit more that I need to do sometimes a second discogram just to confirm, just to be sure, because I'm sure we'll talk a little bit later about this, but we start to see more and more treatments for earlier stage of disc degeneration. So, or kind of that shift to try to avoid waiting until the disc is too far gone, moderately to severely degenerated, and try to catch those patients earlier on in their cascade of disc degeneration in the mild to moderate zone, in which you could potentially stop degeneration or even reverse it. So very excited to talk about some of those treatments with you a little bit later.
Yeah, very exciting. We're moving into more of a regenerative approach. And of course, regenerative medicine is a very hot kind of phrase and topic right now. But I like what you said about maybe catching a little bit earlier, because it's these stories to talk about a very common area as well, knee osteoarthritis. And so you hear about a lot of people, going, getting knee treatments, knee injections, go on to have a replacement, those kind of things. You hear all different varieties and basically variations on a theme with this story. But the one that always breaks my heart and just makes me very frustrated is the patient with severe end-stage Kilburn-Lawrence grade 4 osteoarthritis in the knee, going and getting, some PRP or, some joint gel basically shot up.
Yep.
And we know at that point that the cat's out of the
too far
bag.
gone. Yeah.
And so, yeah, exactly. So it's exciting to think about the analogous process in the disc, maybe being able to halt some of that cascade of inflammation.
Absolutely. It is the same thing. It is choosing the right treatment at the right time. So that's why I think the pathways to treat the disc are more complex than other pain generators. We cannot do always the same thing for the same anatomical region, but we note that there is different pathologies within the disc, and you need to choose the right treatment for the right pathology within the disc.
Thank you so much for listening. If you haven't already, be sure to follow, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable MSK on Instagram, X, or LinkedIn. BackTable MSK is hosted by Jacob Fleming,
Michael Barraza,
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles, Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Judy Dela Cruz.
Thanks again, and see you next time.